today's class in the infection of skin, soft tissue. 15% of the patient presents to OPD or indoor with skin and soft tissue infection. So, this is the anatomy of the skin, epidermis, dermis, and lower part is subcutaneous tissue, fascia, then muscle and bone. Skin is the largest and thinnest organ, serves as an anatomical barrier and protects the internal organ from external environment. What are the functions? Body temperature maintenance, excretion of water, salt, synthesis of important chemicals, acting as a sensory organ. Normal microbial flora, pH. So what are the normal microbial flora skin have? Why the skin disinfection is very important while collecting the sample. So there are some normal flora that is always present in the skin, among which the coagulase negative staph like Staphylococcus epidermidis, micrococci, diphtheroids, anaerobes, or sometimes Staphylococcus aureus may colonize over the skin. Can anybody tell what is the most common organism that is colonized in the nasal cavity or anterior layers of the healthcare worker, which may cause hospital acquired infection? There are many studies where the colonization of which bacteria is very dangerous in a healthcare worker, which can lead to hospital acquired infection. There are many studies of colonization of Staphylococcus aureus. Methicillin resistant Staphylococcus aureus may be there in the nasal cavity of healthcare worker, that may lead to hospital acquired infection. So skin, soft tissue infection. So these are the some skin lesions. Macule, papule. Macule is flat and non-palpable but less than 5 mm. Papule is elevated and less than 5 mm. What is nodule? Elevated and more than 5. Vesicle, fluid filled blister, bulla, fluid filled blister more than 5 mm. The size is important. If it is less than 5, then it could be macule if there is no elevation. If there is elevated, it is papule is less than 5. So vesicle, most of the virus infection like herpes or chickenpox may cause blister. Pustule, pus filled less than 5, and abscess when the size of the lesion is more than 5. So macule, dermatophyte can present as macule. Secondary syphilis can present as macule. Molluscum contagiosum, scabies and warts can present as papule. Nodule, Corynebacterium diphthery. Bulla may be in Clostridium species in gas gangrene, and Staphylococcus aureus may cause bullous impetigo. Extravasation of blood is petechiae. If it is less than 2 mm, when it is 2 mm to 1 cm, it is called purpura. Purpura may be due to decrease in the platelet, or this purpura may be due to cytomegalovirus infection, meningococcal infection, endocarditis. So this may present as papule in even dengue also, dengue viral hemorrhagic fever. So in your question, if there is a mention of these things, you should think of these infections. Now let's start. Some infections are of hair follicles, sebaceous gland and sweat gland and nail. Fascia, necrotizing fasciitis. You already have a class. Can anybody tell What are the organisms responsible for necrotizing fasciitis? One commonest organism causing necrotizing fasciitis. Good. That is one. Wound infection, maybe surgical site infection, bite wound, burn wound, and infection of sinuses or fistula. This you should know. Vascular injury may lead to skin infection, diabetic foot, decubitus ulcer, and some manifestation of systemic disease. This is a question. A 55-year-old male patient attend the ortho OPD with pain and swelling over right knee. There is fever and tenderness. Radiology shows periosteal thickening and signs of osteomyelitis. Gram staining shows gram-positive cocci in groups. It is a simple question. What is the causative organism and other organism causing osteomyelitis? So, osteomyelitis features, there may be, if it is chronic osteomyelitis, there may be a sinus. If the acute osteomyelitis, the periosteal reactions in the X-ray. What is the lab diagnosis and management? Another question, sometimes this type of question can come, a 60-year-old diabetic who underwent hysterectomy a month ago in a surgical outpatient department and complains of discharge. What is your clinical diagnosis? Enumerate the etiological agent and discuss in detail prevention and treatment of above clinical condition. Now, what is the clinical diagnosis? What you should write as clinical diagnosis? Organism not mentioned. What is the clinical diagnosis in this case? So, this is post-surgical within 1 month. So, this is surgical site infection. Surgical site infection would be the clinical diagnosis. Etiological agent, what are the common etiological agents? You have to mention gram positive and gram negative both. Staphylococcus aureus, coagulase negative staph can be hospital acquired infection like gram negative bacilli, pseudomonas or other enterobacteriaceae, all can be positive agent. Though patient is not admitted, but what is the definition of surgical site infection? That should be within a month, 30 days. And if any surgery which has some implant, then up to 90 days is surgical site infection. So, surgical site infection is one question. Now, risk factor, wound class type and prevention and treatment. What is prevention? Either just preoperative or intraoperative antibiotic, shaving to be done properly and local disinfection before surgery, and perioperative or intraoperative antimicrobial prophylaxis. So, these are the points for prevention and treatment according to the disease. So, Staphylococcus aureus infection. So, what are the common skin infection you should know? Bacteria you should at least know: staph infection, strepto infection and anaerobic clostridium. I am not covering the anaerobes in this class, that will be long class. So, Staphylococcus infection, what is the major difference between the Staphylococcus infection? Once explain why has come, why Staphylococcus aureus infections are limited, but Streptococcus is a spreading type of infection. To the presence of fibrin, Staphylococcus, the coagulase of fibrinogen is, though that's why the staphylococcal infections are usually localized. So, staph, catalase positive, coagulase positive. Let me just, if gram positive cocci is given in the exam, you cannot write all the features. Any GPC, whether in a cluster or chain, For theory exam, first you do a catalase test. If catalase is positive and catalase is negative, if catalase is positive, it is staph, and if catalase is negative, it is strepto. Then other test, staph, do a coagulase. If it is coagulase positive, Staphylococcus aureus, and negative, coagulase negative staph. Streptococcus according to the hemolysis. Group A Streptococcus, Group B, or Enterococcus like Group D. So at least this much you should know when any GPC, gram-positive cocci, how you should differentiate. So Staphylococcus in grape-like clusters and Streptococcus in chain. Their golden yellow pigment produces beta hemolytic colony on the blood agar. So what are the infections caused by Staphylococcus aureus? Folliculitis, furuncle. Folliculitis means infection of the hair follicle. Painful pustular lesion in hairy in most regions due to infection of the hair follicle that extends to become true abscess. So folliculitis and furuncle. When the other batch will go and read the OSPI, there is a question on this. Folliculitis and furuncle caused by Staphylococcus. Carbuncle, severe painful lesion, abscess, collection of pus. Mastitis, breast abscess, impetigo, surgical site infection, most common cause. So, what is the most common cause of surgical site infection is Staphylococcus aureus. Most common cause is Staphylococcus aureus. Now, the pastular lesion of Staph aureus infection usually heals quickly because this is the answer that explains the fibrinous wall around the abscess tend to prevent the spread of the organism. Therefore, care should be taken not to break the fibrinous wall by manipulation or trauma. So, when you are draining the abscess, you should not disturb the septa also, septa or the barrier. Otherwise, the infection will be a spreading type. In most of the other cases, in late stage, you have to remove the middle barrier to collect all the pus from the abscess because drainage is the treatment. Drainage must be done. Now, septic arthritis, osteomyelitis, pyomyositis, abscess can occur. Respiratory tract infection, VAP, post-viral pneumonia, empyema, and pneumatocyst. Now, this is a picture of staphylococcal folliculitis and staphylococcal abscess. The size matters. I was mentioning most common site of colonization is anterior nares and oropharynx. So there are many studies of healthcare workers taking swab from the anterior nares to exclude Staphylococcus aureus or methicillin resistant Staphylococcus aureus infection. Now this you all know, nutrient agar, blood agar, selective media. Now what is the selective media for Staphylococcus aureus? Sometimes when you are only searching for Staphylococcus aureus, what you should, the whole class will be late. Staphylococcus mannitol salt agar is the most selective media, mannitol salt agar. And what is the treatment you should give? You should know about staph, about MRSA, methicillin resistant. How will you check MRSA? MRSA, what is the disc used or what molecular test you can do to exclude methicillin resistant? So this is mannitol salt agar, it will produce a yellow colored colony. MRSA, how will you check? Either in disc diffusion, you use cephozetine or make a gene. So these are the 2 points. MRSA may come separately as a short note. So make a gene and suppositin in distribution. So this is gram-positive cocci in clusters. This is golden yellow pigment in nutrient agar, and this is in the blood agar. There is hemolysis in the blood agar for Staphylococcus aureus, that would be beta hemolysis or complete hemolysis. Coagulase test, tube coagulase is positive and also slight coagulase is also positive. Now treatment, when it is methicillin sensitive, anti-staphylococcal penicillin like cloxacillin and napsylin, vancomycin is inferior in term of efficacy, but when it is MRSA, drug of choice is vancomycin. What other drug can be used in MRSA? Linezolid is one drug good that can be used. If quinolone is sensitive, you can use quinolone, but usually community acquired MRSAs are resistant to quinolones also. So you have to give antibiotic according to the sensitivity test. Already, this is the streptococcal infection. Next is Streptococcus. We also had covered. Streptococcus is usually sensitive to penicillin, and streptococcal infections are usually commonest infection is necrotizing fasciitis. You should remember. And what is the treatment of necrotizing fasciitis? Surgical debridement as early as possible, whether it is a gas gangrene due to Clostridium or due to streptococcus. Surgical debridement is the treatment of choice. Now there are some fungal infection, ringworm. Can anybody tell what is this infection? Hypopigmented patch, itchy and pruritic, maybe non-pruritic. Rich in sebaceous gland, neck, chest, upper arm. Yes, it is a case of pityriasis versicolor or. So what you can see, this is I have put it because some MCQ can come. This is a specific appearance, spaghetti meatball appearance in KOH. Skin stepping in 10% KOH will put the spaghetti meatball appearance specific of pityriasis versicolor. কিভাবে স্যাম্পল নেওয়া হয়? ডার্মাটোফাইটের স্কিন স্ক্র্যাপিং এর মতো অনেক সময় স্কিন স্ক্র্যাপিং ভার্সিকালারে নেওয়া যায় না। তো ইউ মে সেলোটেপের মতো প্লাস্টিক টেপ ইউ ক্যান পুট ওভার দ্য স্কিন and that sellotape or can be put into KOH and can be seen. So that is one point. And what is the media? Some olive oil overlay and fried egg colonies can appear. Now dermatophytes. Dermatophytes, 3 species, Trichophyton, Microsporum and Epidermophyton. So they are in, when it is in the skin, it is Tinea corporis. So Trichophyton can infect all 3, skin, hair and nail. Microsporum M not for N. That means Microsporum usually does not involve nail, and Epidermophyton does not involve hair. So these are the few species. These are the 2 most common, Trichophyton rubrum and Trichophyton mentacrophytes, Microsporium odoni and Epidermophyton flocculosum. These are common. They are also zoophilic. That means can be sprayed from animal. এছাড়া কোথায় আসে ডার্মাটোফাইট কোত্থেকে আসে? অ্যানিমেল ছাড়া they usually come from soil. So they are acquired by direct contact with soil animals. Patient is infected. So the একসাথে থাকলে using same dress or same towel may lead to dermatophyte infection spread. Now this is Tinea capitis, infection of the scalp. Tinea fasciae, infection of the non-budded area. Tinea pedis, infection between the toe Tinea corporis, non-hairy skin in the body. Tinea crudis, infection of the groin area. Tinea barbae, infection of the bud area, and Tinea unguium and Tinea manum. At least you should remember these three. That is Tinea corporis, Tinea capitis in the scalp, and Tinea pedis, infection of the web space. Oh, Tinea capitis, Tinea fasciitis, this is Tinea pedis, and this is Tinea corporis. Wood lamp examination, OPD examination, fluorescence is due to presence of pteridine pigment. কি করে নেওয়া হয়? স্কিন স্টেপিংস নেওয়া হয়। হাউ টু ডায়াগনোজ? স্কিন স্টেপিং বা নেল স্টেপিং বা হেয়ার। হেয়ারে কি দেখা হয়? হেয়ারও এর মধ্যে পার্সেন্টেজ অফ KOH স্কিন স্ক্রেপিং এ 10%, নেলে 40%, হেয়ারেও 10%. So this is an hair and this is outside the hair, that is called ectotrix, and when it involves the shaft of the hair, that is endotrix. So these are, hair should be put in 10% KOH. So যখন hair নেবে, part of hair follicle, hairটা পুরোটাই দেখতে হবে KOH put, তাহলে ectotrix, endotrix you cannot differentiate. কি কি করা হয়? কালচার মিডিয়া, সেভারাল ডেক্সট্রোজ আগার উইথ সাইক্লোহেক্সিডিন, পটাটো ডেক্সট্রোজ আগার করা যেতে পারে। এগুলো অত ফাঙ্গাস অত ডিটেইলসে যাব। নাও আফটার কালচার হাউ উইল ইউ স্টেন? বিফোর কালচার ইট ইজ KOH, ফাঙ্গাস আফটার কালচার মোস্ট কমনলি স্টেন বাই ল্যাক্টোফেনল কটন ব্লু. ল্যাক্টোফেনল কটন ব্লু ইজ দ্য কমনেস্ট LPCB tease mount. Already we have covered some infection, folliculitis furuncle and onychomycosis is the nail infection. In many instances, infection of the epidermis may involve the deeper subcutaneous tissue. Anaerobes, I have not mentioned about anaerobes. Mixed infection or facultative organism may lead to anaerobe. Melanese ulcer. Another short-term question, slowly progressive chronic infection begins as an ulcer, may lead to subcutaneous necrosis. Anaerobic cellulitis, সবাই জানে anaerobic cellulitis by Clostridium perfringens is the commonest organism. What is the media we should use and what are the sample you should take for anaerobic cellulitis diagnosis? এটাতেও কিন্তু আসতে পারে, তাহলে how should mention? Superficial skin swab would be a good sample. Swab is not at all a sample. Any anaerobic organism you have to take the sample from the deeper tissue. So bit of necrosed tissue or deeper muscle tissue you have to take from deeper tissue and you have to transport in some transport media immediately. You cannot send it like swab because that will kill the anaerobe. So you have to send it either in Robertson cooked meat media. Robertson cooked meat media, not only the culture media, it is also a transport media. And you should read about RCM also, how the anaerobiasis occurs. Not covering now. So you should send, so necrotizing fasciitis, serious life-threatening condition because it leads to septicemia. So fasciaকে একবার ইনভলভ করে দিলে it will go to spread infection below fascial level, that is muscle and bone. So that's why necrotizing fasciitis is so dangerous. Most common agent are group A Streptococcus, Staph aureus or anaerobic bacteria, Bacterial Infections and Clostridium species. What is Fournier's gangrene? Rare and fulminant necrotizing fasciitis of the perineum and genital region, usually polymicrobial infection. যেখানে এই সব কোশ্চেন যদি থাকে সার্জিক্যাল সাইট ইনফেকশন, স্পেসিফিক জিপিসি বা জিএনবি না দেওয়া থাকে, you should write both. জিপিসি জিএনবি দুটোরই ফুল প্রতিটার বায়োকেমিক্যাল লিখতে হবে না, অ্যাটলিস্ট লাইক দিস, যেটা জিপিসিটা করলাম, জিএনবি যদি থাকে you should do a inoculation in the mat. প্রথমে সাইজ শেপ ম্যাকে inoculation, either it is a LF colony or NLF colony. If it is NLF colony, go for the oxidase test. যদি অক্সিডেজ পজিটিভ আসে সিউডোমোনাস, না হলে আদার এন্টেরোব্যাকটেরিয়াসি। আর এনএলএফ একটা কমন অক্সিডেজ নেগেটিভ, কিন্তু এন্টেরোব্যাকটেরিয়াসিতে পড়ে না, বাট কমন অর্গানিজম ফর হসপিটাল অ্যাকোয়ার্ড ইনফেকশন ইজ অ্যাসিনেটোব্যাক্টার। আর এলএফ যদি থাকে তাহলে কমনলি ইকোলাই, ক্লেবশিয়েলা, these are the two common lactose fermenting organisms. So this at least mention in the flow chart that you have thought about gram positive cocci and gram negative bacilli both. Like in diabetic foot, it must be polymicrobial. In a road traffic accident, that is also polymicrobial. Surgical site infection, nearly 3%. Most common cause of surgical site infection is Staphylococcus aureus. If it is in the gastric surgery or GI surgery, E. coli or anaerobes, and environmental sources are Pseudomonas and Acinetobacter. So surgical site infection, you have to mention all these. When a question of surgical site infection can come, because one of the hospital acquired infection can come as a question. Previously, ventilator associated pneumonia has come as long question. So one question from hospital acquired infection may come. So if it is surgical site infection, mention at least all and mention the flow chart for GPC and GLP. Bites and scratch mark. Animal and human bite, most common in dog and cat, leads to various infections like cellulitis and systemic infection. Infection caused by dog bite, capnocytophaga is a common infection caused by Pasturella and rabies. This is a surgical site infection. একটু বেগে গেছে ছবিটা তোলার সময়। A indoor burn patient complains of bluish green discharge and he was admitted for 14 days in the hospital. What type of infection it is? 14 days, burn patient admitted in hospital presenting with, you see that there is a bluish green discharge from the burn wound. What is the infection? Pseudomonas is the commonest. So Pseudomonas aeruginosa, when it is bluish green has been mentioned, so Pseudomonas aeruginosa would be the type of. So what type of infection? This is a hospital acquired infection in burn patient or secondary infection. This type of infection, SSI, then you have to define SSI also, the hospital acquired infection. Then most probable organism is Pseudomonas aeruginosa. How will you proceed for lab diagnosis? You have to mention the whole other GNB also. First is primary staining. Any bacteriological diagnosis, mention a primary stain, that is primary gram stain. Second day followed by culture, and after culture, the again gram staining and some biochemical test. So in this stage, oxidase test has to be done. ম্যাকে কি হবে, NLF colony আসবে আর নিউট্রিয়েন্ট আকারে there will be bluish green pigmentation. এই কোশ্চেনটা তোমাদের পরীক্ষাতে এসছে বোধহয় 2-3 বছর আগে. This is a WBUHS question. So precaution to be prevent such infection. Precaution কি precaution নেবে? এক হচ্ছে daily dressing of the burn wound and prophylactic antibiotic. কি prophylactic antibiotic দেবে? So what are the two most common organisms for burn infection? One is Pseudomonas, another is methicillin resistant Staph aureus. So antibiotics should be chosen that both are covered. Both are covered. Either you give an anti-pseudomonal drug and the same drug can cover the MRSA also like that. যেমন যদি oral কোনো OPD patient কে burn patient নিয়ে আসে, you can use ciprofloxacin because ciprofloxacin may be useful in MRSA and also pseudomonas. So quinolones can be useful, anti-pseudomonal penicillin can be useful. These are and third generation cephalosporins are useful for like cefoperazone. They are useful in burn injury, massive destruction of the skin, so hospital environment of endogenous flora. Initially, ফার্স্টের দিকে Streptococcus, Staphylococcus দিয়ে colonize হয়, reaching a maximum load and eschar is formed and usually a vascular eschar. At all details. So these are the pathogenesis. Pathogenesis was asked. So this is the pathogenesis for burn wound infection. Gram-positive bacteria initially থাকে 4 days up to eschar is formed over the burn wound. Avascular eschar, যেহেতু vascularity থাকে না, favors the bacterial colonization. Wound is colonized with microbes from the GI tract and upper respiratory flora. Most common organisms: Pseudomonas aeruginosa, Staph aureus, Acinetobacter, Escherichia coli, and Klebsiella. Again, burn wound, what type of infection can occur? Burn wound in impetigo, surgical. Why cervical site wound infection in burn? There may be some debridement. Debridement surgery may be there in burn, so that's why cervical site infection can occur. And bluish green discoloration points towards Pseudomonas aeruginosa infection. So that was the question. What is the specimen? Purulent wound agent. Always if there is a skin and soft tissue infection, first mention the sample as aspirated pus. Swab is not a good sample. If there is no pus, then only you can send swab. Otherwise, try to send pus aspirated in a screw cap sterile container as the sample for skin infection. Swab, even if you send swab, send at least 2 swabs. One swab for the staining and one swab for the culture. If you are sending swab where pus is not available, at least 2 swabs to be sent. Sometimes a quantitative culture may be done on tissue biopsy. More than 10 to the power 5 CFU indicate a serious infection. Treatment: surgical excision of the eschar, extensive debridement of the necrotic tissue, and skin grafting. What are the topical antibiotics? Topical antimicrobial: sulfadiazine cream or silver nitrate cream can be used. Systemic antibiotic. Sinus tract infection. Sometimes there is sinus tract like chronic osteomyelitis. There may be sinus tract. Occasionally developed a channel called sinus. Organisms frequently involved are Staphylococcus aureus and gram-negative bacilli. Fistula. What is the difference between sinus and fistula? Abnormal channel connecting epithelial surface. So, 2 internal organs or organ and the skin. So, both side opening. Sinus has usually single-sided opening. Fistula has both-sided opening, either in the other surface or in the deeper organ. So, what are the skin manifestations of systemic infection? Meningococci can produce purpuric spot. Gram-negative bacilli, Pseudomonas, rose spots. Lupus vulgaris in case of Mycobacterium tuberculosis. Rickettsia bartonella and fungal infection, Candida, Cryptococcus, Histolymus. So these are the organisms that along with involvement of the skin produce systemic infection, because Cryptococcus even in HIV patient, you may have a skin lesion initially, followed by cryptococcal meningitis. Initially, meningitis may not develop. Initially, skin may be involved, or lungs may be involved in cryptococcus, followed by, and this is true for all dimorphic fungus. These are all dimorphic fungus, histoplasma, blastomyces, coccidiosis, and also cryptococcus and candida. Patients with diabetes have a higher risk of developing infection, especially in the lower extremity. What is the treatment? What is the diabetic foot? Diabetic foot সাধারণত কেন হয়? দুটো pathogenesis. It is diabetic complication. One is atherosclerosis, so vascularity is decreased, and as there is diabetic neuropathy, patient cannot feel pain. So diabetic neuropathy exacerbates the diabetic foot. Excess blood glucose leading to microvascular circulation and peripheral motor and sensory both. Motor and sensory both neuropathy occurs. So skin damaging, ধাক্কা লাগছে বা ইনজুরি হচ্ছে রাস্তাঘাটে চলতে গিয়ে উইদাউট ইউজিং শু অনেকে চলে আমাদের স্টিল রুরাল এরিয়াতে, that lead to the secondary infection and starting of diabetic foot. What is the treatment? If it is necrosis is there, a small ulcer is there, that necrosed part should be removed surgically. The treatment with oral antibiotics may not suffice. It is all there. It is already there is necrosis. So again, what is the sample? Aspirated pus and debrided infected tissue. Wound swab from ulcer is not an ideal sample because along with the aerobic, in diabetic foot there may be some anaerobes also. As vascularity is decreased, oxygen supply is decreased, so anaerobes may also grow in diabetic foot, like Bacterial Infections. যদি Pseudomonas হয়, Pseudomonas is strictly, what are the two organisms which are strictly aerobic in your syllabus? They cannot grow without oxygen at all. One is Pseudomonas aeruginosa, another is Mycobacterium tuberculosis. At least remember two names. Those are strictly aerobic, they cannot grow without oxygen at all. Are anaerobes commonest? যদি রোড ট্রাফিক অ্যাক্সিডেন্ট হয় তাহলে ক্লস্ট্রিডিয়াম, যদি জিআই সার্জারির পর হয় বা কোনো ডায়াবেটিক ফুড হয়, ব্যাকটেরিয়াল ফ্যাজিলিস ইজ দি কমন অ্যানারোব ইনফেকশন and usually polymicrobial. আমি ওই জন্য মেনশন করছিলাম when you are writing any question about diabetic food, mention both GPC and GLD. Decubitus ulcer কাদের হয়? CVA patient বা অনেক সময় একসাথে জায়গায় আছে. These patients are decubitus ulcer, bedridden patient prone to develop. The most common site হচ্ছে lower extremity বা sacral region. Most frequent organisms are GI, bacterial fasciitis, যেহেতু it is in the low back area or sacral area near to anus. So GI anaerobic part is to be covered also for decubitus ulcer. Lymphadenitis, inflammation and enlargement of the lymph node. So bacterial causes of lymphadenitis: Bartonella hanseni or cat scratch disease, Francisella atypical mycobacteria, Mycobacterium tuberculosis, Salmonella, Staphylococcus aureus, Yersinia pestis and Yersinia enterococcus. তার মধ্যে Yersinia এখন তো আর হয় না, plague. So this was one of the lymphadenitis present করে. এখন Bartonella can be seen, is also called vagabond disease. Bartonella atypical mycobacteria may present as lymph node and Mycobacterium tuberculosis. Mycobacterium tuberculosis এর lymph node কোনখানে commonly হয়? Mediastinal lymph node হতেই পারে pulmonary tuberculosis এর জন্য, otherwise cervical lymph node হয়. How will you feel in clinically? The tubercular lymph node হবে. Can anybody have palpated a tubercular lymph node? One is when it is in the cervical lymph node or palpable lymph node. The lymph nodes are usually, tubercular lymph nodes are usually matted. They are attached, lymph nodes are Matted lymph node. So more than one lymph node attached together, a matted lymph node can be seen in Mycobacterium tuberculosis. Virus causes of lymphadenopathy, CMV, Epstein-Barr virus, parvovirus and rubella. Toxoplasma gondii and coccidioides histoplasma can present as mediastinal lymph node. Malassezia furfur is the seborrheic dermatitis or Tinea versicolor. Lymphangitis, group A beta hemolytic streptococcus, staph, the most lymphatic filariasis and brucea and Eucheria bancrofti. Bacterial diagnosis already I have covered. How will you diagnose the lymphangitis of filariasis? Eucheria bancrofti, brucea malae. Ki kore diagnose korbe, what sample to be taken? One is creeping eruption, maybe a skin, because these worms enters our body through skin penetration. So local creeping eruption may be there. And what are the samples to be taken for diagnosis of filaria? So what do you want to see? Ki dekhte chaicho. So this, in case of peripheral blood to be taken, peripheral blood, ki dekha hoy? Look for the microfilariae, the larval form. They have a nocturnal periodicity, 10 p.m. to 2 a.m. রাত্রের দিকে blood collect করতে হয়. If it is not possible, you can do a DEC provocation test, that is diethyl carbamazine may be given and blood may be collected after 1 hour. So DEC provocation test may be done. Other than this, so microfilaria এই ক্ষেত্রে কি হয়, অনেক সময় you can use a special method, the Knots method, to hemolysis of other RBC so that microfilaria can be seen clearly. So microfilaria, remember, of Eucheria bancrofti and brucea malae are the two common found in our area, and the microfilaria is the larval form. Other skin lymphangitis by sporothrix. Sporothrix তোমাদের ক্লাস হয়েছে, sporothrix কাদের হয়? Sporothrix shenkai infection. It is also, এই কোশ্চেন যদি তোমাদের এমনি ছোট ছোট আছে, যারা রোজ গার্ডেনে কাজ করে, গোলাপের কাঁটা থেকে ইনফেকশন হয়, দ্যাট ইজ রোজ গার্ডেনার ডিজিজ, is sporothrix shenkai. Musculoskeletal infection, sometimes muscle infection, bacterial myositis, viral myositis, parasitic myositis and fungal myositis. I am going through quickly. Staphylococcus is the common cause of pyomyositis, Suas abscess, Staph, Strepto, E. coli and Mycobacterium tuberculosis. Suas abscess, Mycobacterium tuberculosis, these abscess in the back paraspinal area is what it is called. Abscess due to Mycobacterium tuberculosis is called cold abscess. Cold abscess because there are usually no signs of inflammation. So tubercular abscess, paraspinal area involving the spine, TB spine, produce cold abscess. Streptococcus necrotizing fasciitis is the most dangerous, following necrotizing myositis, Clostridial myositis, Clostridium perfringens. Let's know few infection, viral infection that can cause myositis. HIV, human T lymphocyte virus, influenza, dengue, poxocytic. These all can present with myalgia that may be due to involvement of muscle by virus, viral myositis. Parasitic myositis, cysticercosis, trichinellosis are associated with cysticercosis ke kore, which organism? Muscular cysticercosis ke kore? Tinea solium করে। Tinea solium causes the cysticercosis, both neurocysticercosis and other mothers, this is by Trichinella spidalis. Fungal Candida species is the common, Cryptococcus, Histoplasma, Coccidioides. So in all HIV infection or opportunistic infection, Cryptococcus and other dimorphic fungus to be mentioned. Other skeletal system may be by direct invasion following a trauma, surgery and from hematogenous spread. Again, Staphylococcus aureus is the most common cause of acute osteomyelitis, followed by Streptococci and gram-negative bacilli, mainly E. coli. আচ্ছা, একটা এমসিকিউ আগে আসতো, what is the common bacteria for osteomyelitis in a patient with sickle cell disease? Sickle cell disease, Salmonella is the organism which usually causes acute osteomyelitis. Salmonella in sickle cell disease. যেমন Pseudomonas usually does not cause pneumonia, কিন্তু Pseudomonas কিন্তু cystic fibrosis patientদের pneumonia করতে পারে. So these are the few points that should be known. So with sickle cell disease, increased risk of Salmonella osteomyelitis and sternum is a common site. Vertebra most common, hematogenous spread. Other than long bones and pelvic bone, clinical manifestation, fever, local pain and swelling and redness নিয়ে প্রেজেন্ট করে। কি করে প্রেজেন্ট করবে? তাহলে vertebra যদি ইনভলভ হয়, other than common bacteria, you should also exclude tuberculosis. Tuberculosis exclude করতে হবে। A small piece of infected bone যদি পাওয়া যায়, না হলে কি হবে, ব্লাড কালচার ইন কেস অফ হেমাটোজেনাস স্প্রেড, বোন বায়োপসিস ইন কেস অফ histopathological examination, radiology can show periosteal thickening and CT and MRI can reveal the location of osteomyelitis. Early institution of pathogen appropriate antibiotic. তাহলে তোমাদের you should think of whether it is a gram-positive cocci or gram-positive infection or gram-negative infection, start antibiotic accordingly. সুতরাং প্রাইমারি গ্রাম স্টেনের রোল কি? প্রাইমারি গ্রাম স্টেন তাহলে প্রথমেই তুমি জানতে পারছো whether it is a gram-positive infection or a gram-negative infection, and empiric antibiotic before sensitivity can be chosen. So that is the role of primary smear. Joint infection সাধারণত হেমাটোজেনাস স্প্রেড থেকেই হয়, maybe monoarticular commonly. Bacterial arthritis, again Staph aureus is common, Strepto is the second common, Neisseria gonorrhoeae, H. influenzae, Pseudomonas aeruginosa and Bacteroides may be recovered. So Lyme arthritis, Borrelia burgdorferi. Lyme disease, how will you know, other than arthritis, what are the features of Lyme disease? Anybody? Arbovirus infection, chikungunya and Zika virus. Chikungunya main features ki? Chikungunya কিন্তু non-hemorrhagic fever. কিন্তু chikungunya involve করে joint pain. Joint pain persists even after fever subsides. এরপরেও 1 মাস 2 মাস joint pain persists, so that is chikungunya. Chikungunya কি করে diagnose করবে? How will you diagnose chikungunya? Chikungunya against like dengue, কোনো অ্যান্টিজেন NS1 অ্যান্টিজেন পাওয়া যায় না, you have to do chikungunya IgM antibody. IgM antibody বা long standing হলে you can do an IgG antibody also. So chikungunya can only be diagnosed by IgM antibody against chikungunya, that is MAC ELISA. Same similar method like chronic hepatitis B. কখন chronic বলবে? Chronic hepatitis B কখন chronic বলবে? After how long? কতদিন? আর কিভাবে chronic active hepatitis আর chronic hepatitis এর মধ্যে ডিফারেন্স? Chronic active hepatitis আমি আজকে কভার করছি না, you should read when it is called chronic and chronic active hepatitis এ কি কি মার্কার থাকে। Chronic active hepatitis এর কি কি মার্কার থাকে আর chronic hepatitis কখন বলে? This could be a question in your final also. Dracunculus meninensis, Echinococcus granulosus. Echinococcus granulosus কি করে? Echinococcus Hello? Echinococcus granulosus কি ইনফেকশন করে? Hydatid cyst. Hydatid cyst is the infection caused by Echinococcus granulosus. Now the synovial fluid and the specimen directly inoculated. যদি যে কোনো sterile fluid থাকে তাহলে you have to inoculate it in brain heart infusion broth or any broth for multiplication of the organism, because at the sterile site the number of organisms are very less. সুতরাং কালচারে নাও গ্রো করতে পারে. So all the sterile fluid, when you are writing any answer on sterile fluid, should be sent directly inoculated into blood culture bottle for better recovery. এটা যে কোনো sterile fluid, not only synovial fluid, like blood culture, other sterile fluid যে কোনো জায়গা থেকে নিলে, like pleural fluid or ascitic fluid, you use this term যে we are putting for multiplication. Blood culture bottle. আর skeletal infection, এটা মাঝে প্রবলেম হচ্ছে। গেছে, ব্যাটারি চলে গেছে। Leishmania can cause some skeletal infection. Leishmania কোন ফর্ম আমাদের বডিতে পাওয়া যায়, কোন ফর্ম কালচারে পাওয়া যায়? Amastigot we get in our body, promastigot we get in the either in the vector or in the culture media. Culture media কেউ বলতে পারবে what is the culture media used for culturing Leishmania? NNN media. Good. NNN media. এটাতে বেসিক্যালি ব্লাড আগার থাকে এবং তার উপর একটা ফ্লুইড ওভারলে থাকে for culturing these. In HIV patients, certain opportunistic pathogen may cause disseminated infection involving bone marrow also. Now larva migrans. Larva migrans I have kept because short note can come, and this has come many times as short note. What is the larva migrans? Some non-human hookworm. Non-human hookworm, if it enters in our body through skin, they cannot complete the life cycle. So that's why they cause larva migrans. So this is the question produced by nematodes of lower animal like Ankylostoma brasiliensis, Ankylostoma caninum. Their infective form is filariform larva. They transmit by skin penetration. Kintu jehetu this human is not a natural host, these are larva currents. Larva currents mean the spread or the speed of this larva is high. Strongyloides circularis, this can cause the larva currents. Larva migrate to various organs, develop into adult form. This is a normal in lower animal. Lower animal, this is their life cycle, but in human, they cannot penetrate. These lower animal cannot accidentally infect man, but they cannot complete their normal development, and the larva wander aimlessly in the skin. Cutaneous larva migrans or creeping eruption, serpiginous, and rate of production is less than 1 to 2 centimeter per day. 1 to 2 centimeter per day হচ্ছে larva migrans, and for larva currents it is 1 to 2 centimeter per hour. The difference in the speed and larva currents is caused by Strongyloides tuberculosis. So ground itch, rate of progression and intermittent involvement. Additionally, the pattern is haphazard. Diagnosis by clinical feature. Key treatment korbe larva currents. What is the larva migrans? What is the treatment given? Same anti-helminthic, either you can give albendazole or you can give other anti-helminthic drug. Albendazole is effective. Thiabendazole that rarely cause skin site infection. So these are. Any question from your side? তাহলে স্কিন ইনফেকশনে অন্তত ব্যাকটেরিয়াল পার্ট, ফাঙ্গাল পার্ট অ্যান্ড দি প্যারাসাইটিক পার্ট ইউ শুড মেনশন। আর বেশিরভাগই কোশ্চেন আসার সম্ভাবনা সার্জিক্যাল সাইট ইনফেকশন থেকে বা বার্ন উন্ড থেকে। So at least you should remember what are the common organisms in which infection. In surgical site infection, what is the commonest organism? It is Staphylococcus aureus. Other GMB as hospital acquired infection. In burn wound, Pseudomonas aeruginosa is the commonest. Staphylococcus aureus or other Acinetobacter that can be an organism for these infections. So at least remember these bacteria and mention the flow chart I have drawn for gram-positive cocci and also gram-negative bacilli. Minimal flow chart you should draw.